Hello, my name is Thomas Moore, and this presentation is a short summary of my recent work regarding outcome and outcome measure reporting in randomized control trials for the pharmacological management of neurogenic overactive bladder. This work was undertaken at St George's University of London. Neurogenic overactive bladder is a chronic syndrome of the lower urinary tract as a result of injury to the nervous system with symptoms of urinary incontinence, urgency, frequency, and nocturia. These patients represent an extremely heterogeneous group and have diverse and complex management requirements. Despite this high prevalence and the significant impact this syndrome has, there is no consensus on the outcome and outcome measures that should be collected and reported in trials evaluating interventions. This lack of consensus leads to inconsistencies in the reported outcomes, reducing cross-trial comparisons and hindering any large-scale meta-analysis opportunity. This causes significant resource waste and directly impacts the quality of care clinicians can deliver to their patients. These issues could be addressed by developing a standardized set of outcomes that would be measured in a particular research area, known as a core outcome set. To understand the variation in outcome reporting in this area, we undertook a literature review using MBAS, Medline, and the Cochrane central databases from inception to October 2020. The search criteria included the MESH terms for overactive bladder, urinary urgency, urinary incontinence, neuropathic, and neurogenic. This database search was independently undertaken by 2 assessors. The trials of interest were randomized control trials exclusively assessing pharmacological interventions for neurogenic overactive bladder. They had to be written in the English language, assess population over the age of 18, and contain 5 or more patients. All studies had their whole text screened for eligibility, and outcomes and outcome measures were extracted and placed into a comprehensive inventory. The outcomes were then grouped into domains, which allowed for the management of a large number of similar and overlapping outcomes. These domains were then grouped more broadly into themes. The literature search identified 588 trials. After screening and duplication removal, there were 23 eligible trials. These trials' references were then reviewed, finding 8 more eligible trials, as seen in the flowchart, and further to this, 11 articles were identified through hand searching. This produced a total of 42 trials with 4,617 patients. A total of 290 outcomes and 80 outcome measures were extracted from these articles. This table shows the 2 most commonly reported outcomes in each theme. As you can see, there is significant variation between outcome reporting frequency. For example, maximum systometric capacity was the most commonly reported outcome, being reported in 40 out of the 42 trials. Next was 24-hour incontinence frequency, being reported in 29 trials. And then after this, there was a significant drop in the reporting frequency of outcomes in all themes, with the majority of outcomes being reported in less than 5 trials. The results from the analysis of the outcome measures can be seen here. These 3 domains showed the greatest variation in their outcome measure reporting. Firstly, the lower urinary tract symptom domain used 16 different outcome measures. Of the 16 used, 11 were bladder diaries of different lengths, ranging from 24 hours to 28 days. Another domain which displayed widespread variation was patient-reported outcomes, which had 19 different outcome measures. The most commonly used questionnaire was the Incontinence Quality of Life questionnaire, used in 15 trials. 13 of the measures in this domain were only used in a single trial. And finally, the most commonly used outcome measure in the urodynamics domain was urodynamic studies, which occurred in 21 out of the 42 trials. This term is ambiguous and highlights a lack of clarity in many of the measures being used. This systematic review confirmed the presence of variation in outcome and outcome measure reporting. Firstly, there was a significant range in outcome reporting rate, with maximum systometric capacity being reported 40 times, compared to 75% of the outcomes which were reported less than 5 times. There was variation in the rate of domain reporting, with 8 out of the 14 domains having a reporting instance of less than 30%. These infrequently reported domains include pain, treatment success rate, and mortality, which is concerning and highlights the need for future trials to report in these areas. This variation in outcome reporting is unlikely to be due to the range of interventions, as there was a large amount of similarity between the interventions investigated. Across all domains, there was a significant amount of variation and lack of clarity in the outcome measures reported, and this can clearly be seen in the urodynamics and patient-reported outcome domains. The heterogeneity seen is similar to other systematic reviews in urology and gynaecology, and this hinders the ability for meta-analysis and comparisons between interventions, which could negatively impact patient care and lead to research waste. Furthermore, there is significant variation in outcome measures being used across all trials, which can affect accuracy, format, and precision of the outcomes reported. Moreover, the outcomes found in this review highlight that many trials only target a small number of key stakeholders, mainly the patients, and they're rarely relevant to all parties. To conclude, this systematic review supports the development of a standardized set of outcomes, a core outcome set, to resolve the highlighted issues regarding a lack of standardization and heterogeneity. This will allow for all future research to be guided and promote consistent outcome reporting. Before the process of developing a core outcome set has been finalized, we've proposed the use of an interim set of outcomes based on the commonly reported outcomes from this review, with the domains and outcomes listed on screen. We also recommend that each of the outcomes is assessed with a validated measure. Thank you.